Hello, everyone. Welcome and thank you for joining the Interventional Psychiatry Consortium, an educational network bringing together trainees and other advanced learners for a shared educational experience in the rapidly growing field of interventional psychiatry and neuromodulation. My name is Yaakov Green. I'm one of the organizers of the consortium alongside Simi, Ailani, Jeff Zabinski, and Jarrod Ehrie, our speaker, as well as our advisory board. We're now over 400 members strong, representing over 70 institutions from around the world. Thank you for being a part of it. If we could just share, Dr. Ehrie, if you could share the screen, let's look at the calendar. Today is the third talk in a phenomenal lineup of speakers covering a variety of topics, as you can see here. Please note that on Tuesday, September 30th at 6 to 7 p.m. Eastern, we are having a special presentation. We're partnering with our colleagues at the American Neuropsychiatric Association Neuromodulation Special Interest Group to host a talk led by Drs. Charlie Palmer, Mark George, and Roy Hamilton, entitled Towards Interventional Brain Medicine, the commissure between neurology and psychiatry. You don't want to miss it. If you haven't already, please sign up to receive invitations to future events and also take a moment to complete our brief survey. As for today, we will soon hear from our speaker. Then we'll have a Q&A, during which time you can use the chat to ask a question or raise your hand to be unmuted. The sessions are recorded and will be made available to you all. Now I am thrilled to introduce our speaker. Jarrod Ehrie is an interventional psychiatrist at Stanford University, where he is the director of the outpatient SAINT TMS clinical service. In addition to SAINT, he provides clinical care on the conventional TMS, ECT, ketamine, and S-ketamine services, and sees patients in the depression clinic. He is also an assistant training director for the Stanford General Psychiatry Residency Program, and he is the medical director of the Stanford Brain Stimulation Lab, where he serves as a study physician on several neuromodulation clinical trials. I've had the pleasure of knowing Jarrod when he was with me at Columbia. He is an absolutely brilliant and compassionate clinician and a great guy. It is my pleasure to introduce Jarrod Ehrie. Go ahead.
Excellent. Thanks so much, Yaakov. I really appreciate the wonderful introduction and good to see everyone here this morning. So today we're going to be talking about TMS. And we're going to talk about, so start with some disclosures here. One, I have no conflicts of interest to disclose here. And two is that the citations are in the speaker notes for each slide. So afterwards, happy to share the slide deck. And if you're interested in what I'm talking about on any individual slide, you can find a specific citation in the footnotes there. In terms of kind of questions to kind of think about as we go through this talk, think about kind of for what patients you would think about or recommend TMS. Question two is what distinguishes accelerated TMS from conventional TMS? And three, when would you consider referring for accelerated TMS rather than conventional TMS? And so kind of when I was preparing this talk, my assumption and my understanding about a lot of people here is that many of you have been exposed to at least a lecture or some content on TMS and or have had some clinical exposure to TMS. So I will make sure I define my terms and cover the basis of TMS, but a lot of our focus today will be on recent innovations and kind of progress that we've made in recent publications around TMS. So without further ado, first I want to define my terms here. So when I say TMS, we're talking about transcranial magnetic stimulation, which kind of broadly defined is the delivery of magnetic pulses over the scalp to stimulate the brain directly. And I have on my right side one of my kind of preferred figures that's kind of showing what a TMS coil looks like. So this black object here is a kind of a black plastic case that has within it a loop of conductive wire that forms in a repetitive figure 8. And this coil is then connected to a device, which is basically just a control panel and a capacitor, which itself is plugged into the wall. And when you deliver an electrical current through one of these coils, it then generates by design a perpendicular magnetic pulse, which then crosses the skin, subcutaneous fat, the skull, meninges, and so forth, and then hits the surface of the brain, the cortex, where it then turns back into an electrical field or generates an electrical field, which is what we're trying to do with TMS. On this kind of figure here, there's kind of 2 points of interest that I wanted to highlight, which are illustrated in these kind of or these bullseyes. Over the motor cortex is where we initially stimulate as part of motor thresholding to figure out the level of cortical excitability, which is then used to dose TMS. And then two, one of the brain regions that we use to target treatment for major depressive disorder is the left dorsolateral prefrontal cortex, or left DLPFC, which we'll be making reference to. It's not the only target for depression. The dorsomedial prefrontal cortex, or DMPFC, is also an FDA-cleared target for major depressive disorder. But this is certainly the one that's been maybe kind of most widely studied and most widely used in clinical context. In terms of what we're using TMS for, in the United States, TMS is cleared for a few different indications. It's cleared for treatment-resistant major depressive disorder. It's cleared for anxiety, or it's actually initially approved, I should say, for MDD. The subsequent are all FDA cleared. Anxiety comorbid with MDD. Then there's refractory OCD. There's smoking cessation, and there's migraines with aura, which is actually a take-home single pulse device. And I kind of listed these, and what I've seen clinically is kind of in descending order of frequency of use. I think it's worth noting that the coils and placements differ between indications. The coil that you would use for major depressive disorder or OCD would not necessarily be the same coil you would use for smoking cessation or migraines with aura. And those are differently shaped coils, which are different brain targets. Now, the typical TMS protocol for major depressive disorder, the one that's still kind of most widely available and is kind of part of the initial protocol that was used, is 6 weeks typically of once daily treatment. Some coils were kind of initially studied with 4 weeks, like the BrainsWay, but the typical course is 6 weeks of once daily treatment. So patients usually come in on a Monday, Tuesday, Wednesday, Thursday, Friday, so the work week, and then come in for 6 consecutive weeks. And then most insurances approve 36 treatments. So often there's an opportunity to do some additional tapered treatments. Here at Stanford, we do 3 treatments the next week, and then 2 treatments, then 1 treatment for a third week as part of our kind of attempts to kind of taper treatment and preserve benefit as long as we can. And then treatment itself is targeted to the brain region based on a tape measure in effect. So you can see in the bottom left an illustration of these different anatomical landmarks that are used to develop a grid over the head, a scalp heuristic to use to target treatment. So Nasion to inion, tragus to tragus, and then the circumference of the head are used. And then the way that you actually identify in the context of the DLPFC, the left DLPFC, there's a kind of a few different options. Initially, people, when you found the motor cortex, the motor threshold, you would then advance the coil kind of along the surface of the scalp about 5 centimeters to try and hit the left DLPFC. More recent innovations have sometimes used 6 centimeters or 5.5 centimeters. And another kind of further intervention was to use the use EEG markers, landmarks, so the F3 landmark in particular, to target treatment with the so-called beam F3 method, which then subsequently there's an adjusted version of that to try and, again, more precisely target. But all these are different ways of effectively developing a scalp heuristic, and you can use these brain measurements, or these head measurements, to identify a brain region. The advantage is that tape measures are cheap and widely accessible. The downside is that one size fit all approach, no matter kind of how kind of slick the method is, the surface of the head does not kind of fully correlate with brain regions kind of definition, and you could potentially be targeting over say a sulcus instead of a gyrus. But one of the kind of innovations that we had that really kind of changed clinical practice in the last 10 years or so is the use of a different protocol of stimulation. So I want to talk through that. So theta burst stimulation, and I'm quoting from a paper here, is a paradigm of rTMS, which is repetitive TMS, that enhances cortical excitability through enhancement of synaptic transmission by mimicking cortical theta rhythms. So the original FDA-approved protocol of TMS, had a very standardized frequency of treatment. So it was like a 10 hertz frequency, for example. You deliver 10 pulses, magnetic pulses within a second, and that was kind of how it was dosed. But here is trying to kind of mirror more of the kind of actual underlying activity of the brain. And so I'll show this in the next slide, but TBS is a 50 hertz triplet of pulses delivered at a 5 hertz interval. So 3 pulses with that at a high frequency, and then a slightly lower frequency. Those kind of sets of 3 are then delivered. And so ITBS, or intermittent theta burst stimulation, it generates neuronal excitatory effects that, at least in the motor cortex, are reminiscent of high frequency rTMS. So it's similar, and arguably, to the 10 hertz protocol. Continuous theta burst stimulation causes suppression of neuronal excitability as presumed in low frequency rTMS, so more akin to the 1 hertz protocol. I think it's really important to note that there's some evidence challenging this binary understanding of excitatory and inhibitory effects. But a lot of this work was initially done in the context of the motor cortex, and it's less clear how well that really extrapolates to brain regions we're targeting with a much more kind of complex looking neuronal connection with excitatory and inhibitory neurons running in various directions that we see in things like the dorsolateral prefrontal cortex, for example. And so there's other hypotheses about mechanism, the prokurtosis hypothesis, the idea that we're kind of causing more of a regression to the mean. There's a variety of ways of potentially understanding this, and given that there's still emerging data on this, I'm not going to kind of spend too much on kind of understanding of the mechanistic effects of TMS today, but just to note that this excitatory inhibitory binary is likely an oversimplification at the very least. This is a figure that demonstrates these protocols that I discussed previously. So under standard TMS, there's the continuous protocol, which is 1 Hertz frequency for a certain number of seconds. And then the 10 Hertz protocol is usually a period of high frequency stimulation, 4 seconds, an initial protocol. And then there's a period of time between those runs of high frequency stimulation that's part of the typical 10 Hertz protocol. And then over here is the kind of the contrast with the theta burst stimulation. So this is the continuous theta burst. Intermittent theta burst stimulation means 2 seconds on, 8 seconds off, repeated in that pattern every 10 seconds. And then here in this kind of insert here is a diagram of the theta burst stimulation protocol in general, where you have this triplet of pulses that are delivered at a 50 Hertz interval. And then these triplets themselves, as I mentioned before, delivered at this 5 Hertz frequency. And so this is kind of an illustration of the most common protocols that are currently used in TMS. Now, this has kind of been compared in clinical trials, and I think the so-called 3D trial, Blumberger et al., 2018, is still, I think, one of the landmark studies of clinical efficacy that looks at both ITVS and 10 Hertz protocols in terms of clinical efficacy. So there was an open label trial of 414 patients, or participants, I should say, with MDD who had failed at least one antidepressant. That's the standard that was set by the O'Riordan initial trial, that one antidepressant failure is often the inclusion criteria for TMS trials, which compared the 10 Hertz protocol to the ITBS protocol. And so I'm going to kind of cover some of the clinical efficacy data out of this. So first of all, when I use the term response in MDD, major depressive disorder, by that I mean a 50% improvement in a standardized scale of depression severity. And so on the Hamilton scale in this study, for those who received the 10 Hertz protocol had a 47% response rate, and that's 49% on the ITPS. The remission rate, or percent of people who got so much better on this standardized scale they no longer met criteria for even mild depression, 27% of people met remission criteria with the 10 Hertz protocol, as compared to 32% on the ITPS protocol. And so this was mostly a non-inferiority study that showed that we see similar clinical efficacy with the 10 Hertz protocol and the ITPS protocol. Why this is, I think, most interesting and relevant, though, is the time that it takes for each of these protocols. So there's various ways that the 10 Hertz protocol is delivered, but initially it was delivered over 37.5 minutes. And the ITBS protocol with 600 pulses, which is the standard for most ITBS, is about 3 minutes and 9 seconds. And so that is a huge difference in time. And that's a difference, practically speaking, for patients. They can get in and out faster, but also for clinics. In practice, including time to check in and get in the chair and get set up and so forth, you can do, almost 3 times as many patients clinically with ITBS. You can do, patients every 15 minutes versus kind of more like every 45 minutes with the 10 Hertz protocol. And so this really improves kind of throughput for clinics, and this can improve, clinic revenue and a variety of other things. And so I think, since this trial was published in 2018, I think there's been, what I've seen in clinical contexts, is a big move from having a 10 Hertz protocol to an ITBS protocol. Now, running it to ITBS protocol often means having a cooling system as part of the machine, and so often that sometimes requires an upgrade in terms of the clinical device that you're using. But most manufacturers of TMS devices now have a system that can run ITBS. And I think, and kind of setting up briefly for kind of accelerated, I think the fact that we could really shorten the duration of each individual treatment session kind of set the stage for what we'll talk about with accelerated treatment. I'm going to do a brief digression, though, and talk a little bit about pharmacology and TMS, because I will loop back to this later on in today's talk. I'm going to talk about D-cycloserine. So D-cycloserine, you may vaguely recall from past clinical experiences or medical school or what have you, is a medication that's partly used to treat tuberculosis. But in this context, it's worth mentioning because it's an NMDA receptor partial agonist. And the significance of that, and this is from the authors of a paper whose clinical results I'll cite in just a moment, But they describe that synaptic plasticity with continuous and intermittent TBS is NMDA receptor dependent. And an antagonist abolishes the effect of both protocols. And so that led to the idea that targeting the NMDA receptor with low doses of the partial agonist, the D-cycloserine, could normalize the long-term motor cortex plasticity in individuals with MDD. So that's a lot of words to say that there's a kind of an understanding that the mechanism of D-cycloserine kind of potentially could dovetail well to part of our understanding of the mechanism of TMS and could lead to some synergistic effects here, and potentially potentiate the effects of TMS. And so indeed, in a double-blind placebo-controlled RCT with 50 participants with MDD, participants are randomly assigned one-to-one to either ITBS plus placebo or ITBS plus D-cycloserine for the first 2 weeks, followed by ITBS without an oral adjunct for an additional third and fourth week of treatment. And the difference was striking. So rates of clinical response were higher in the ITBS plus D-cycloserine group than in the ITBS plus placebo groups, 74% versus 29%, as are rates of clinical remission, 39% versus 4%. So really significant difference here between having this adjunct and not having this adjunct. And I think this has generated a lot of interest. This is, one study. I think replication is necessary, of course, but that kind of really appeals to the idea that there might be some kind of potential synergy here between these medications. And, I think ongoing research is going to be interesting in seeing this used. But now I'm going to pivot to what I'm going to mostly focus on today, which is accelerated TMS. And the first thing that I want to do is describe what I mean when I say accelerated TMS. So there's a variety of definitions. So I'm going to start with one from a systematic review, which define accelerated TMS as at least 3 ITBS treatment sessions per day during at least 4 days a week with a total stimulation/treatment duration of 1 week. But other definitions have been broader and have included any protocol with multiple TBS or sometimes even multiple TMS sessions a day. And there's really significant heterogeneity in clinical trials in terms of the number of pulses per TMS session, the number of sessions per day, the duration of the intersession intervals, and the targeting method used in this study. And I'm actually going to illustrate this, and this is again from one of these review studies, and this is a figure kind of trying to describe what the core elements of accelerated TMS are. And what you're going to see here is significant variability. So some people use TBS, some use rTMS, and hopefully you can see my cursor as I kind of go through this, but high frequency, low frequency, continuous versus intermittent. I think I missed it in there. Differences in the interstimulation interval between individual trains and also between sessions. Also, the number of treatment days between 2 and 30, between 2 and 10 sessions a day, between 600 and 1800 pulses per session. Use different targeting methods are used, the 5.5 centimeter method, the BMF3, structural MRI, resting state functional connectivity, kind of et cetera, et cetera. And some use the combination of medications or other combinations as well. And so I think accelerated TMS, unfortunately, as I understand it, or accelerated intermittent TBS, or the variety of ways people even talking about this, there's a lot of variability in what that means. And so I'm going to cover some clinical trial data from a number of different protocols, but it's in no way kind of reflective of the full kind of complement of ongoing research in this area. But before I kind of get into specific kind of protocols that are being used and their evidence base and so forth, I want to start with kind of how we even got to the idea of accelerated TMS. Like, what is the reason that we're even thinking about giving more TMS being more efficacious? So I'm going to start with the kind of question, which is like, how much TMS is the right amount of TMS? Like, where do we plateau in terms of benefit for more pulses? Do we run into a risk of kind of side effects or adverse effects with more pulses? Like, how do we even know how much is the right amount? And one of the studies that I think stoked interest in this was a study of 33 patients with major depressive disorder who did not respond to a typical course of BrainsWay TMS for 5 days a week over 4 weeks. As I mentioned before, some of the BrainsWay trials use 4 weeks and 20 treatments instead of 6 weeks. And they were given an extended course of twice weekly TMS. 24 participants, or 72%, achieved responder status with continuation TMS on at least one of the weekly assessments. 27% did so within the first week of this additional phase, 42% within 3 weeks, and 60% within 4 additional weeks of TMS, or 8 total weeks of active TMS. I'm going to show this in a figure in just a moment. So this is the figure from this study. You can basically see is that as we give more TMS, we get more and more people who reach response. So as we're kind of just giving more and more treatments over more and more weeks, we're just seeing more and more of an effect. And it's kind of unclear. I mean, you could draw a variety of kind of lines on this graph about whether or not we're having kind of a asymptotic kind of flattening, or whether or not we're kind of seeing more of a linear effect. But the short answer is that we kind of didn't reach a kind of a clear point of futility in this study. And one of the kind of core questions that I think continues to kind of occupy or kind of this field is like, is it more treatment sessions or is it more pulses that is leading to this greater benefit? So I'll share one study that I think kind of elegantly looked at this. So 208 participants with TRD were randomized to receive either DL-PFC, ITBS, 600 pulses, delivered twice daily with a 54-minute interval between treatments, or a single TMS session of 1,200 pulses with one sham treatment with the same interval between treatments, to ensure equal levels of daily therapeutic contact and blinding of patients and raters. So what this meant is that patients came in, and everyone came in for 2 sessions. They either came in for a session with 600 pulses, sat around for an hour, got another 600 pulses, or they got 1,200 pulses in one session and then had a sham session that was 54 minutes apart. And the question was like, what had greater efficacy? And there were no significant differences between the two groups. And the author's conclusions here was that these results suggest that twice daily ITBS does not accelerate response to ITBS and is not different from once daily treatment in terms of improving depressive symptoms in patients with TRD. And also there was a subsequent study that looked at the same thing from a DMPFC perspective and kind of ended up with similar results. And so this is kind of fuels, I think, part of the argument that really it's just the magnetic pulses rather than the sessions. And you note that there was a kind of a very specific 54-minute interval between treatments. I decided, because I think it got a little bit kind of too in the weeds, but there is some existing literature, mostly based initially on rodent data, that the interval between TMS sessions might be important. That particularly between ITBS, that something around the hour mark might have more cumulative benefit than if we have a shorter or potentially longer period of time between pulses. But again, I'm not going to. If you have questions, I can answer those. I'm not going to get into the full weeds on all that data. So kind of getting back to this question of, is it more sessions or more pulses? One review of accelerated TMS reported initial evidence that increasing the number of sessions per day, the total number of sessions, and the total number of pulses each appear to have a positive relationship response rate, which was postulated to be linear. But as you can kind of imagine here, these parameters are fundamentally interrelated, as more sessions per day typically equates to more sessions in total, as well as more pulses. So I think that the jury is still a little bit out, and like whether or not more sessions of TMS or just more pulses of TMS really leads to this kind of greater benefit with more treatment. But I'm now going to pivot to kind of talking about one particular protocol, which is SAINT, and one of the accelerated protocols. I'm going to talk a good chunk about SAINT for kind of 3 reasons. One is that the one that I think has the most data behind it, has double-blind data, and kind of has had most kind of replication. 2 is it's the one FDA cleared accelerated protocol that insurances are currently covering, which I could talk more about if you guys are interested later, but insurances cover SAINT, and it's widely available in that context. And 3 is that I have the most experience with SAINT. I run our SAINT clinical service here at Stanford, as Yaakov mentioned at the beginning, and I also helped participate in some of the clinical trials that have been done with SAINT, and so it's also the area I can speak to most kind of cleanly. But I want to talk about some of the ways that SAINT in particular is kind of compares to the conventional TMS protocol that I laid out at the beginning. So first, I want to kind of, again, define my terms. So SAINT stands for Stanford Accelerated Intelligent Neuromodulation Therapy, or in some publications, it's referred to as Stanford Neuromodulation Therapy. And I'm not going to get into like why there's a difference or 2 different acronyms at this point. But I want to talk about how it compares to conventional TMS. So first, duration. So SAINT is delivered over 5 days, so usually Monday through Friday in the outpatient context, and 10 sessions are delivered a day. So you have 10 sessions of them, and they're spaced at about a 50-minute intersession interval, so about 50 minutes between them. So typically, since it's a 10-minute treatment, as we'll talk about, it's about kind of on the hour, or you kind of consistently get the treatment. Each session of SAINT is 3 times as long and contains thus 3 times as many pulses as in a conventional ITBS TMS treatment. So typically most ITBS, and is about 600 pulses, and then in SAINT it's 1,800 pulses. And in terms of the amount of pulses thus delivered, do a little bit of math here. If you're doing each session or 3 times as long, you're doing 10 sessions a day, you are doing, in effect, 30 times as many pulses in a given day as you would do in a conventional ITBS protocol. And because we do 30 sessions in general, that's where you get the same number of pulses in a single day of Saint as you get over a typical 30-day course of conventional ITBS TMS, which is 18,000 pulses. And then, of course, over the 5 days, then Saint delivers 5 times as many magnetic pulses, ITBS pulses, as in a course of conventional ITBS TMS. So that's one difference, or kind of two differences. One is kind of the schedule of treatments, but also as a result, the schedule of sessions and then the number of magnetic pulses. But there's a few other ways that Saint differs. Firstly, it uses an MRI, right? So we talked about how in most ITBS TMS, we use a tape measure, right? And that probably works well for some patients who are hitting the perfect spot. For some patients, it may be hitting the edge of the right spot, or in some patients, may be missing entirely because we're using these scalp heuristics. Saint allows us to target very specifically the brain region you want to hit and make sure we're hitting, a gyrus and not a sulcus. And in particular, though, it's not just a structural MRI. It's, in fact, we use a resting state functional connectivity MRI. And why do we do this? Well, we want to target not just the anatomic area of the left DLPFC, but we actually want to target a specific part of the left DLPFC with a maximum negative connectivity to the subgenual anterior cingulate cortex. And I'll provide some context why. And I know Sean Siddiqui joined last time. He joins today. Maybe he can kind of extrapolate on this, because I'll start with a somewhat simplified version of this. But based on functional MRI data that we have, and Michael Fox's group at Harvard did a lot of this foundational work, there are a few brain areas that look very different under functional connectivity for someone who is depressed compared to someone who's not depressed, or compared to a normal healthy control. And two areas in particular that I'm going to highlight here is that the DLPFC is hypoactive, as I understand it, compared to people who are not depressed. And so that area has less activity. And this deeper region, the subgenual anterior cingulate cortex, which is too deep to target directly with TMS, is hyperactive in people who are depressed. And so there is a kind of an argument or an idea that because these two brain regions are kind of so markedly kind of out of sync in depression compared to people who are not depressed, that they might in some ways arguably be part of a kind of depression circuit, if you will. And in fact, there was some simian data, some monkey data over this summer that kind of tried to kind of track this with a rather elegant study, which kind of suggested that perhaps that the connection between these two brain regions might actually go through the dorsomedial prefrontal cortex, as I understood that paper. And that kind of would make sense since we have TMS for DMPS at the DMPFC, which also treats depression. Other people, though, have postulated different ways that these two brain regions are connected. So I should just note that I don't know if that's been clearly demonstrated, the connection between these two in humans at this point. But nonetheless, there's kind of an argument that there's a connection between these two brain regions, and as we'll show in some clinical data, that connection might make a difference in terms of clinical efficacy. And so really the goal, though, overall here, and again, I don't want to get too much into the weeds here, but the goal is to target the optimal part of the DLPFC, and arguably this is one way of finding the optimal part of the DLPFC to target. I want to share some of the evidence base for this anticorrelational targeting approach. So this was based on a study with 41 patients who underwent conventional TMS to the left DLPFC. Antidepressant efficacy was predicted by stimulation sites that were more negatively correlated with the subgenual cingulate with a low p-value. This is a study which showed the degree of subgenual connectivity that's been mapped against the degree of clinical improvement. You can kind of see on the Beck Depression Index, and you can kind of see here that the greater degree of negative connectivity based on this figure, then the greater clinical efficacy we're seeing. Subgenual connectivity was also a significant independent predictor of antidepressant response in multivariate analyses. You can see that the magnitude of effect from the subgenual connectivity outweighed some other things like people's gender or age or concurrent medications or what have you. And so this was kind of the basis by which subgenual connectivity was introduced as part of the protocol for Saint. And I want to kind of show how that actually kind of looked in practice. So this is from the initial open label Saint TMS clinical trial that was published a few years ago. And what I want to illustrate on this thing is that on these three views of the brain, blue is the average F3 location. So we think about the beam F3 as one targeting mechanism for conventional TMS, and you can kind of see where that is. And then you can see where all of the targets were using the fMRI targeting method used in Saint. And then also you can see to what degree these actually lead to clinical benefit. So the more red the number was, the greater percent improvement in the Montgomery-Asprey, the MADRS depression rating scale. And then the more yellow or green it was, the less kind of benefit was seen in that patient. You can see that there's not a kind of a clear cluster here. So you can see that, you have kind of dark circles, if you will, dark red circles that are kind of all over the place. And it's not that it was all clustered in, say, one region per se. But all these are, most kind of functional sites were notably rather lateral, rather posterior, and rather inferior compared to the beam F3 target. Or the F3 target, I should say, not the beam F3 target. But all of which I think hopefully is interesting, but I want to talk about what the clinical evidence base has been so far for SAINT. So an initial open label study of 22 participants with TRD, 90.5% of patients in the 4 weeks after getting treatment met remission criteria. So again, that's percent of people getting so much better they no longer met criteria for even mild depression. It was 86.4% in the intention to treat analysis. And then in the subsequent double-blind randomized controlled trial, which had 29 patients with TRD, the remission rate in the active arm was 78.6%. And notably, the remission rate in the sham, which we use in device literature to talk about the fake treatment or placebo treatment, was 13.3%. And so I think it's worth kind of reflecting here that the remission rates were very high in both the double-blind trial and then also in the open label trial, 78.6% here, 90% here. But I think also one thing that I think is of interest is the degree to which this separated from sham treatment. I think many of us are familiar that in the antidepressant literature, there's often a difficulty these days of being able to demonstrate separation between active treatment and placebo treatment. Some of you may have seen the March 2025 American Journal of Psychiatry paper kind of highlighting that esketamine, for example, this intranasal ketamine version, had a hard time in clinical trials separating from placebo, not because we saw low response and remission rates with esketamine, but because we saw such high rates of response and remission in the placebo arm. And so I think it's just kind of notable that in this SAINT trial, we saw such low sham response rates, remission rates. This is a figure from the double-blind trial published in 2022, Ko et al. That kind of the filled in circles showed sham. You can see that at no point did they have more than 20% improvement in their MADRS scale versus in the active arm of SAINT, where kind of at all time points out to 4 weeks after treatment, we saw a greater than 50% improvement on average in terms of the MADRS score. But now I want to kind of, pivot, and I'm going to circle back to some other accelerated TMS trials and some of their data in just a moment. But I want to kind of briefly talk about duration of benefit while we're on the context of SAINT. So, they're based on kind of a review study from a couple of years ago from 2023. So, and I haven't seen anything else I'm aware of, but I could have missed something. To my knowledge, none of the accelerated TMS studies other than SAINT have reported on antidepressant effects that follow up longer than 4 weeks after treatment so far. And there's kind of been often a question with accelerated TMS, like what is the durability of effect? Maybe it has acute effect, but is it durable? For SAINT, there is one publication now, open label data at 12 weeks, which suggested that 47% or so of participants who remitted acutely from SAINT remained in remission, and 43% of participants who responded acutely remained responders at the 12-week mark. The authors concluded that 12-week remission rates were comparable to ACT and even potentially exceeding acute remission rates of ITBS and high-frequency TMS protocols in similar patient populations. But just wanted to kind of share that. But that does mean that, some patients get better, but then lose the benefit. And so what are ways that we can kind of work around that in the context of SAINT? And so the first question is like, what if you repeat SAINT? What if you kind of do it again? And so there was a publication, 27 participants who had SAINT once were then retreated. Participants again had to meet the initial kind of criteria of a major depressive episode of at least moderate severity with a MADRS greater than or equal to 20. And pair-T tests did not reveal statistically significant differences between courses and percent changes in any assessment. That is that kind of whether, you seem to have similar effects in the first and second round of SAINT. And this kind of is a nice figure that kind of illustrates this. 74% of participants remitted at the immediate post-visit, which was kind of usually done on the Friday, so like the fifth day of treatment. 74% got better both times, 8% only got remitted the first time, 11% only remitted the second time, and 7% of people did not get to remission at immediate post in either kind of treatment arm. And so here is just another figure that shows this. This kind of shows baseline MADRSs on both the initial index and retreatment. At baseline, at immediate post, and then 1 month, you can kind of see that they kind of, basically the index and retreatment looks similar. And so the upshot is that this is still early data, small data, open label data, but seems to suggest that retreatment of SAINT is kind of maybe as effective as the initial index course. But I think, nonetheless, like I think there kind of remains a question of like, kind of like, what about maintenance or ongoing treatments in the context of SAINT? And so 21 participants with TRD who had entered remission the week following treatment with SAINT were then enrolled in an optimized SAINT continuation treatment paradigm with the goal of maintaining remission or MADRS less than or equal to 10. MADRS was collected every other week in this study, and a proprietary algorithm was used to give patients additional SAINT treatments in somewhere between 1 and 5 days when they started to show signs of relapsing based on these MADRS scores. On average, in this study, participants required about 15 additional treatment days over the course of 12 months, but the majority of them were relatively short. So 69% of additional treatments consisted of 1 to 2 days of SAINT to maintain wellness. And over the 12 months, participants maintained remission for an average of 85% of the monitoring period and response for 95% of the monitoring period with an average MADRS of 7. And this is the figure from that study. So what this kind of shows, you can see that enrollment stayed pretty good. So initially 21 participants, and then it kind of stayed that way. Maybe one person was lost at the very end. But this was the initial remission. And you know, in order to be in this study, you had to have remitted. So of course, everyone gets into remission. What's striking here is that on average, participants remained in full remission throughout this year-long follow-up period. And I think that this is kind of compelling because I think often we have rapid active treatments, you know, things like IV ketamine and a variety of things, but often the question from patients that I get is like, okay, maybe this gets me well, but how would I stay well? How would I remain doing well kind of long-term? And this is some data showing that potentially we could retain this in the context of at least SAINT out to a year or so, at least. But I want to kind of briefly, before I pivot to other accelerated protocols, mention some of the limitations of SAINT research so far and how those are being addressed. You know, one is that it's been a relatively small number of participants. As you can see, 22 in the open label, 29 in the double-blind trial. Initially, most are done at our site here at Stanford. Multiple innovations were put into one protocol, and this is a common kind of thing that I hear flagged about SAINT. You know, we're both increasing the number of pulses, we're doing 10 sessions a day, and we're using a functional MRI target. It's a lot of different things we're doing simultaneously. We know arguably can make it hard to know which of those elements most contribute to the high efficacy that we're seeing. And 3 is that we do still need more data on the durability of benefit and ways to maintain the effect. But I just want to mention kind of how we're addressing some of these concerns, or you know, how these things are being addressed. So hopefully, if we give some iteration of this talk next year, we will be able to answer some of these questions, or at least address some of these concerns that are often flagged. One is that we did a second larger double-blind SAINT study, which we've concluded data collection and working on getting that data processed and eventually published. So hopefully there should be a replication study done soon. One thing that I think is really cool, done by Joe Taylor at Harvard, is this, and he had a brain stimulation letter kind of describing his kind of the structure of this recently. He also has a clinicaltrials.gov for this trial, which I put in the notes here. It hasn't been published yet though. But he did this head-to-head trial of patients who got basically the same, as I understand it, the same protocol as SAINT, 10 sessions a day, 1,800 pulses per session over 5 days. But 20 people were allocated to getting the anti-correlated targeting akin to SAINT, and 20 people got the Beam F3 target. And my understanding is that data for this is now collection is concluded, although I haven't seen the results of this. It's called the AINT trial, which I think is cute. And then he also has filed in clinicaltrials.gov a larger replication study with 40 people in each of these 2 arms. And so hopefully we'll be able to get an answer soon about whether or not the anti-correlated targeting, the functional targeting, actually is making the difference, or if it really just the schedule of treatments that even the Beam F3 targeting would be fine. So we're trying to answer that question. And then also, we are also launching a large registry study, or the Magnus, the company commercializing SAINT is. We are one of the sites at Stanford because we have a clinical service where we're going to try to track clinical efficacy over time for these patients and hopefully get some more longitudinal data in a real world context of patients who are getting SAINT. But I want to kind of pivot from SAINT for now, although I'm happy to answer additional questions about it in the Q&A session and talk about kind of what are some other kind of key studies. There's a lot of studies out there. I'm just going to highlight a couple that I think have, at least to me, kind of really stirred my interest and kind of stood out to me. One was a prospective open label pilot study of 21 outpatients with treatment-resistant MDD who were treated with 36 sessions over 5 days in a sequence of 6 sessions on Monday, 8 Tuesday through Thursday, 6 on Friday, using the standard kind of 600 ITBS pulses per session, spaced 60 minutes apart, so akin to what we did at Stanford, and again reflecting some of this kind of interest around intersession interval. And coil placement was based on the scalp anatomical landmarks using the Beam F3 method. So what's cool about this is that in effect this is using the protocol that most insurances are comfortable with. As I mentioned before, most insurances will authorize 36 sessions of TMS, And this is just kind of scheduling multiple treatments over time to try and basically use that with otherwise our standard number of pulses per session and the VMF3 method to see, hey, if we just accelerate what we already do with conventional TMS, is that effective? Like, is that better than just doing it over, 6 weeks and then with a taper? And a total of 21,600 pulses were provided. So slightly more than the 18,000 that is, standard in the 30 days. So it's 36 sessions, not 30 sessions. Similar inclusion and exclusion criteria to SAINT based on my read. And at 4 weeks follow-up, the response rate was 70% and the remission rate was 55% on the MADRS. So it's not, quite as high if looking at remission rates as in the SAINT study. But it is certainly higher than the response and remission that we saw in the 3D study for either the 10 hertz or the ITBS protocol. And so it's possible this is kind of like has, some of the benefits. It's going to be, not as hard to implement as SAINT without, requiring the functional connectivity MRI and everything, shorter days as well for the TMS text, but might have more benefit than the kind of typical protocol. So anyway, I think it's a really kind of cool study. And then one thing that you guys may have heard about, or this is something that's based on a preprint, as I'll mention, but a really cool study about doing just 1 day of accelerated TMS. So bunch of caveats here. This is a preprint manuscript. I haven't seen that it's been published. I checked a few weeks ago last. It was evaluated in a retrospective case series of 33 patients. And so caveats about kind of the data, this would definitely need to be replicated. But pharmacologically in this study, a single dose of D-cycloserine, 125 milligrams, taken 50 to 70 minutes before beginning TMS, and a single dose of lisdexamfetamine, which is Vyvanse, 20 milligrams, taken 50 to 70 minutes before beginning TMS. There's some signal, although I don't think it's as well described as D-cycloserine, that stimulants might potentially potentiate TMS clinical benefits. That's why it was incorporated here, as I understand it. But then there was a course of 20 sessions of TMS delivered about every 30 minutes. And each session was composed of 600 pulses of ITBS at the 120% of resting motor threshold with the VMF3 target. The response and remission rates were 90 and 74% respectively on the Hamilton at 6 weeks, and then still very high numbers with response to remission at 12 weeks in this study. And so again, I think, a number of caveats here, but it's really fascinating. I'm really looking forward to both seeing this study published and also seeing replication of this, hopefully in a double-blind context. So that we'll be able to kind of see, because if we had a really effective 1 day treatment that lasted 12 weeks, right, that would be revolutionary in the treatment of major depressive. I do want to kind of briefly comment on the safety and tolerability of accelerated TMS, particularly as it's kind of juxtaposed to conventional TMS. So as many of you know, the typical risk for conventional TMS is seizure and hearing loss without hearing aids. And then common side effects are scalp discomfort during stimulation, headache, syncope, etc. And so what about with accelerated TMS? Well, from a systematic review of accelerated TMS studies published in 2023, none of the studies to date reported major adverse events, especially no seizures or affective switching. And to my knowledge, although I may have missed something, I don't believe that anyone who's gotten SAINT, either in the research context or clinically, has so far had a seizure. But the most common adverse effects across accelerated TMS studies were fatigue, scalp pain, headache, neck and back discomfort, discomfort at stimulation site, and anxiety and decreasing orders of frequency. So I think the fatigue is kind of notable. And one thing that I've noticed with SAINT is that you're kind of coming in for treatment kind of for longer periods of time. You're sitting around and waiting between treatments, and kind of curious about whether kind of fatigue is seen more often in these studies. But I'll just kind of note that the most common side effect for the left DLPFC ATBS studies was headache, which occurred at similar rate to those reported for conventional once daily TBS. Fatigue was 12% and nausea was 10%, occurring arguably at similar rates to those reported in the 3D study for ITBS. And the studies that performed neuropsych testing did not demonstrate any negative cognitive side effects from accelerated TMS, which is in line with what we see with conventional TMS. And the side effects that were reported were especially observed at the start of the treatment and often spontaneously improved or were improved after analgesic medication. And so my general understanding of this paper and my understanding of the safety data in general for accelerated TMS is that it seems to have a similar safety profile to conventional TMS. In which it suggests that kind of giving more pulses or more sessions did not itself significantly increase the risk of adverse effects or tolerability or safety considerations for patients, which I think is important to flag. Well, I just want to briefly kind of mention the use of accelerated TMS in non-MDD applications, because I know that's all I focused on so far. We did have an initial brain stimulation letter from 2021 that looked at improvements in Y-box for 7 participants who had OCD. And I think it's just worth noting that kind of 3 of these participants at least had really kind of significant and sustained greater than 50% improvement in Y-box, which is particularly striking in OCD because it's harder to see response in OCD. You guys may know that in a lot of clinical trials of OCD, response is often defined at less than 50%, unlike depression. So like I've seen studies with 25% to 35% defining response. And so a greater than 50% response for, a good chunk of patients is impressive. And, we're now replicating this with a larger study in conjunction with Cornell here at Stanford. So I want to kind of be mindful of time. I think I'm right on time, and just kind of re-bring up some of the discussion questions that kind of I just kind of fielded to kind of think about, but happy to expand in any direction. But we want to think about like what patients would you think about for TMS, but in particular, what distinguishes accelerated TMS from conventional TMS, and when would you consider referring for accelerated TMS rather than conventional TMS? And with that, I will stop sharing and happy to kind of take questions.
Thank you so much, Dr. Ehrie, for the incredible presentation, thorough, captivating, clinically relevant. So now for the Q&A portion, what I would encourage our participants to do, if you have a question or a comment, you could raise your hand and I will unmute you and allow your video so you can address the group. If you feel more comfortable asking a question or making a comment in the chat, you are certainly welcome to do so. Perhaps in the meantime, I will, we have Lucianne Bainel. I will allow your camera and allow your mic.
Cool, thank you. First, thank you for this very nice talk. I missed the first part, couldn't attend, but I watched the end. I was very excited about what you presented. It's very interesting. Something I was wondering is about the timing between the stimulation. So I think in Saint is about 50 minutes apart. And what you presented, one of the last slide was 60 minutes. Do you think that matters in terms of, what is happening in the brain?
Yeah, so there's some, what I understand to be at this level, rodent level data that looks at the interval between treatments. And what they showed in that, and I had this in the slides, and I think it got just like a little bit overly kind of complex, but that they kind of around the 50-minute to around an hour mark. And I don't think that distinction between 50 minutes and an hour was clearly delineated in the data that I've seen. But that kind of that when you kind of give like ITBS sessions at say like a 10-minute interval, you kind of don't see this kind of cumulative potentiation or kind of increased activation. But then when you do so at the 60-minute mark and you keep giving additional sessions, you kind of see more and more kind of activation and cumulative potentiation of the cortex in the rodent model. And so that is the kind of data that I understand kind of really informed this kind of 60-minute interval that got incorporated in Saint and in other accelerated protocols. And I think that's kind of where it came from. But to my knowledge, outside of the kind of what I mentioned maybe early on in the talk, where kind of there was a study that kind of compared giving 1,200 pulses in one session or 600 pulses separated by 50 minutes, both with the DLPFC, and there was no clinical difference between giving those at the 60-minute separation or all at one time. And so I would say that at least in humans, it's kind of less clear if really kind of spacing out these pulses across sessions leads to greater clinical efficacy or not.
Interesting. And there is no like fMRI study looking at what's going on with this timing yet?
Not that I've seen. It may be out there, maybe I haven't seen it.
Okay, thank you.
Sure.
Thank you for the question. We have a hand raised by Dr. Pruitt. Let me allow your camera and microphone.
Hi, everyone. Thank you very much for the talk. Dr. Ehrie is great. So I'm currently working on setting up a TMS clinic for a psychiatric hospital and an outpatient clinic that I work at. And one question I have is around the targeting with the MRI versus the BMF3 and the 5.5 or 7 meter rule. Mm-hmm. Do you feel like we have enough evidence right now to suggest one over another? I mean, I understand sort of like why MRI sort of theoretically would be better, but I don't know if we have any clinical trial data to suggest that that's the way to go, or picking any of these is sort of equivalent at this point, or just how you'd counsel a patient if they're asking you about this and how you'd make the decision.
Yeah, no, it's a good point. I mean, I think as I mentioned earlier on, I think one of the limitations of SANE is that it kind of did all these innovations simultaneously, and then it makes it hard to delineate kind of which things are kind of most efficacious. Right now, Joe Taylor's study, kind of the AINT study, where he did these head-to-head comparison, exact same schedule, but BMF3 versus the neuronavigation stuff. I think when that gets published, and also when he does his subsequent replication study on that, I imagine it's going to actually explicitly answer that question. But outside of the kind of I guess my general take is that outside of the specific context of if you're setting up a SANE clinic, in which case kind of the fMRI is kind of part and parcel of what you're doing, I think most clinics are still using, in my experience, using the BMF3 method. And it's kind of not clear that, say, using, say, a structural MRI kind of is kind of consistently better to my knowledge. And so I think, unless you're kind of going fully in and wanting to set up a SANE service with the SANE billing codes and all those things, I probably would, if it was me, I would probably kind of continue what we do in our clinic, which is for conventional TMS, we still use the BMF3 method.
Okay. And when thinking about BMF3 versus like the 5.5, how do you decide between those? And I'm just thinking in the sort of protocol that Mag Venture has given me, there's like this little piece of plastic that you attach to the coil, and that helps you map where it should be after you hit the motor hotspot. Would you suggest not using that and going for the BMF3, or?
Well, there's a fun study. I don't know if you're familiar with the kind of the term the adjusted BMF3 method, but there was kind of a fun study that was done that kind of compared people's kind of fMRI data, as I understand it, versus kind of the BMF3 location, and actually found that if you slightly adjust by like a few centimeters, or actually maybe it's a few millimeters, and that's kind of more effectively aligns on average the functional target. So if you go online and you type in like BMF3 calculator and you put in the three kind of variables, circumference, nasentinian, tragus to tragus, they give both the BMF3 and then the adjusted BMF3. If you've seen this yet, but then so typically what we use, or what I've usually used in this context, is the adjusted BMF3. So that's kind of, as I understand it, they actually have the citation, I believe, on that website that kind of shows kind of how they got to that based on imaging. And so I think about that as even more precise. I'm not aware to date, and there may be, but I'm not aware of like head-to-head trials comparing the BMF3 and the 5.5 centimeter though. And so whether or not that kind of greater fidelity in that context with the adjusted BMF3 leads to greater efficacy, I can't speak to that.
Okay, thank you.
Thank you. Why don't we shift gears and move to the chat for a moment? We have 4 questions that have popped up, and maybe Dr. Ehrie, I could ask you them in as a rapid fire style, so we can move through these. Wendy Fox asks, have there been any studies looking at post-TMS or concurrent with TMS psychotherapy?
What's coming to mind is like psychotherapy and ketamine studies, but I'm not personally aware of, there may be, but I'm not personally aware of that literature.
The next question from Richard Weiner. Not clear how typical the patients in these studies are. Many of the treatment-resistant depression patients we treat are severely ill, some psychotic or even suicidal, some who lack capacity for research consent. Are there any data with SAINT or other forms of accelerated TMS, and where, if any, do you draw the line between TMS and ECT referrals?
It's a good question. I mean, the SAINT kind of protocol require people to have non-psychotic major depressive disorder. They can have comorbidities in these trials. You can have comorbid PTSD or GAD or what have you, but MDD has to be primary. And so co-primary disorders were excluded from that. So you could have borderline, but the primary problem had to be MDD. And also we excluded things that had kind of clear neurological correlates out of kind of concern for the fMRI. So if you had a history of like, significant stroke or multiple sclerosis or a variety of other things, then those would be exclusionary on that basis. And so in my understanding, and I know I'm speaking from the SAINT, but my understanding, I've looked at the inclusion and exclusion from other studies of accelerated TMS, follow a very similar pattern. And I'm not aware of any that currently have evaluated MDD with psychotic features. And so to that point, I think, when I think about my own clinical decision-making, which, we may cover, I think we're going to cover in a later lecture, when I hear psychotic features, I usually think we should probably go for ECT, because the evidence base is that psychotic features may be a positive prognostic factor for ECT. And so I would say that we don't have great data, say, on SAINT and catatonia, for example, or other accelerated TMS and catatonia. So right now, it's really kind of straight up MDD that we have data for. Good question.
Great, thank you. We have two more questions from the chat and then a comment from Nick Trapp, and I want to bring him to the floor once we get through those other two questions. So Andrew Chen, a colleague of ours, asks, great talk, Jarrod. Can you comment on how Saint came up with a 90% resting motor threshold intensity as opposed to, say, 120% that it's more common with rTMS? Have people tried going to higher intensities?
Yeah, I'm going to see. I apologize. I have a slide on this that I didn't include that I'm going to see if I can find briefly. And I've got a bad feeling that I'm not going to be able to pull this up in like a 1 minute. That could just, anyway, there was a study that was done. Yeah, I think you would just be watching me stare at my screen. But there's a really nice figure which we can maybe send around, or we can send over to you, that kind of actually compared the 1800 pulses of ITBS looking at different resting motor thresholds, and 90% was found to be kind of somewhat optimal as compared to like 120 or 110 or 100. They kind of did all the resting motor thresholds and looked at different durations, looking at 600, 1200, and 1800 ITBS pulses. And in fact, just based on that study with that larger number of pulses, it seemed like the 90% resting motor threshold was optimal. One thing I do want to note is that, and maybe I should have gotten into this, but we in Saint actually we do what's called depth correction. And so what we do is we actually kind of look at we take the motor threshold and we kind of then compare the distance between scalp and cortex at the site of the motor threshold, then compare that to that difference at the site of the DLPFC to kind of accommodate for the fact there's actually greater distance, and magnetic fields decay with distance, and accommodate that. So actually, and because of even though we're using a lower percent of motor threshold, often because of the typical distance between the scalp and the cortex, often we are treating people at a greater percentage of resting motor threshold than 90% because of that depth adjustment. And so that kind of throws a little bit of a spanner in kind of the direct head-to-head comparisons there.
That makes a lot of sense. Thank you. One last question, and then we'll move to Nick Trapp. So Gregory Nikogosian asks, do you have any experiences with individuals who have had a higher level of anxiety or even manic-like behaviors from accelerated TMS? Any ideas why this occurs? And do you have any strategies to address this?
Yeah, I mean, I think, well, first of all, that there is a flipping risk with TMS. It's pretty low. If you kind of if you look at some of like the Rossi papers for safety, the kind of absolute increased risk of developing hypomania or mania from TMS is pretty low compared to sham studies, but it nonetheless, like other antidepressant treatments, carries the risk of flipping. And so I think that seeing hypomania or mania is certainly kind of possible. I don't recall that we've seen that in our kind of clinical setting or in a research setting, but we typically exclude people who have bipolar 2 or bipolar 1. And so remind me of the second part of the question. Then there's a second part.
Any idea why that might happen, which you address, and any strategies to address this? And they also note that in their clinic, they switch from left-sided to right-sided treatments with good effect in these cases.
Mm-hmm. Yeah, I mean, I think that there is, some consideration about whether right-sided might be kind of the 1 Hertz right DLPFC is kind of commonly used as a protocol. And we use that sometimes here too. I mean, I will say that if you look at some of the brain sway data, using some of the more conventional depression targets can also treat comorbid anxiety. And that's why there's a separate FDA clearance for anxiety comorbid with MDD. So I typically think about even some of our conventional targets as being efficacious for both. But I certainly have seen that. And sometimes people also do kind of a sequence thing where they'll do, high frequency or ITBS to the left DLPFC initially, and then before the person leaves the chair, flipping and doing a low frequency, like a 1 Hertz, or sometimes even a continuous TBS to the right DLPFC.
We have about 2 minutes left. Dr. Trapp, I think you're a presenter, so you should be able to unmute yourself and turn on your video. There you are. Yeah.
Awesome. Yeah, first, great talk, Jarrod, and so much stuff to cover. This is such an exciting field. So you did a great job getting through a whole bunch of data. Just a couple quick comments and then a question for you. One, related to the BMF3 versus 5.5 centimeter stuff, we looked at that and there was really no difference in depression outcomes. One really interesting thing we saw that kind of relates to Sean Siddiqui's like anxiosomatic and dysphoric circuits was that the BMF3 target maybe was at least trending towards having more improvement in anxiety. So that's something to pay attention to. I think there's some active work in that space. The other thing is I was actually looking at that new 1D Downer paper, And one interesting thing is they mention it's a Beam F3-like scalp heuristic, but if you look at the target they used, it's actually a posterior target that might be more aligned with 5.5 centimeters. So I don't know what that means, but just like a whole nother wrinkle to this idea of targeting being different than Beam F3. The question I had for you, you've probably done, I imagine, more SAINT being at Stanford than most people in the country. I'm curious, we run into a lot at Iowa, like people who are coming in who failed ECT or failed TMS and are asking about SAINT. I'm wondering if you guys have, what you do in that scenario, and also have you had any success there? Because I think that kind of speaks to, is there a different mechanism here as opposed to, you know, an ECT antidepressant effect?
Yeah, it's a good question. So in our clinic, we actually, a lot of people that we treat are failed conventional TMS. Because I think in order to be able to, for Medicare patients, I will have to be able to make some sort of argument for why we're doing accelerated versus conventional. If someone comes into me, they never had TMS before, frankly, because it's easier to cover. I usually do conventional and then I do SAINT if it doesn't work. So majority of our Medicare patients have had it before. We're seeing as good efficacy rates with people who've had prior conventional TMS as those who haven't. It's not really separating based on our kind of internal QIDS and PHQ-9 data. So that seems to work well, even if conventional doesn't. And we often think about it as an option for people who fail conventional TMS. In terms of ECT, I have seen success. I had one patient who had had over 200 sessions of ECT and had kind of not really had any kind of consistent. She's definitely an outlier, but she did meet response 2 weeks after completing it with a QIDS that got, PHQ-9 that got down to 9, so down into the mild range, with improved functional activity. And so we've only had a couple of ECT failures who've run through our clinical service yet, and that was an exclusion in a lot of the clinical trials. So I don't think we have good data yet about that, but I've seen at least one success where someone failed ECT and conventional TMS and then got better with SAINT.
Awesome. Thanks.
Sure.
Thank you so much for the fascinating discussion. Glad to have you all here. Our next talk will be our special talk with the American Neuropsychiatric Association Neuromodulation Special Interest Group on September 30th at 6 to 7 p.m. Eastern. We hope to see you there, and thank you again for joining the consortium, and looking forward to seeing you at future talks.